Good afternoon. Hi, I'm Roberta Robertella. I'm the Associate Dean for Outreach and Engagement here in the College of Public Health and Human Sciences. I also serve as the Program Leader for Extension's Family and Community Health Program. And it is my delight today to introduce to you Dr. Lyle, or LJ Fagnan, who is an alum. He's from Oregon State University, and he's currently a professor of family medicine at Oregon Health and Science University. And we've had an opportunity to meet before today because the Oregon Rural Practice-Based Research Network, which Dr. Fagnan is the head of, had invited me to come talk because they're very interested in this connection between what Extension is doing in family and community health in communities, particularly rural communities, and what the network is doing. So we're looking for ways to collaborate. He's been a general medical officer in the Indian Health Service in Alaska, and now also as a family physician in rural Oregon. He's been the investigator of many studies for the network, with a principal investigator role in 20 of these. He's co-authored what is really a landmark visitation of this issue of how you have practice-based research, and it was in JAMA back in 2007. He also is involved in this effort for health extension, which a few of you may have been to campus a few years ago when Dr. Art Kaufman from New Mexico came up to speak to us. And it's this kind of national collaboration trying to get students thinking about the way extension works in communities and whether or not there's some model that extension can provide to the way physicians could be thinking about work in their communities. And so I believe that that's part of what Dr. Fagnan is going to talk to us about today, moving upstream, health extension and primary care.
Thank you, Roberta. And I really am pleased to be here. I'm a real OSU fan. My favorite sports team plays tonight at 8 o'clock.
Basketball.
I'm really big on the women's basketball team, and I love the coach. And part of it comes from, I actually spent my senior year of high school in Corvallis. My dad took a coaching job. Here I was in Cottage Grove, and so he had 4 kids. I was the oldest of 4, and teacher salary, he figured he couldn't have everybody go to school, so he moved to a college campus and or community and coach. And he coached after I was done. He coached girls basketball. He coached at Corvallis High School and then Crescent Valley, and so my mom is still here. My dad's passed away, but my mom will be 98 this month, and so she's in assisted living at the Caring Place, which is on 23rd Street, not far from here. So I just stopped in to see her. She's had a little fall, but she's coming along. So Corvallis is a place I feel really connected to. And when I went to school here, I wanted to leave home pretty badly because my parents were here. So you could go to medical school after 3 years of college. And so Oregon State University was one of the pipeline schools for what was called the University of Oregon Medical School, which is now Oregon Health and Science University, where I work at. And so they would come down and they would interview students. And I remember, I forget which building or hall, but I expected to be really grilled about why do you want to be a doctor and that. And so my interview was, tell me about the fishing on the Alsea River. How's steelhead fishing? And so that was my time here. So I did go to school here, but I didn't graduate until after my first year of medical school. And so what I'm going to do is I'm going to talk about a community laboratory setting that we've developed over the past 15 years. I work with the Oregon Rural Practice-Based Research Network. We started it in 2002. This year is our 15th anniversary, which anybody know what great 25th, what silver anniversary, right? 50th golden. So 15th crystal. So so our convocation that's going to be on April 20th at Sun River in Bend, held in conjunction with the Oregon Academy of Family Physicians, is looking in the crystal ball to see what we're going to be doing for the future. And Governor Kitzhaber will be giving our keynote speech, and we have the editor of the Annals of Family Medicine, Kurt Stange, that will be there, and trying to lift our spirits up during this time when there's a lot of uncertainty around what I do for a living, you know, as a primary care clinician and being in healthcare, and it's a scary time, you know. So the head of ARC stepped down last week. He'd only been there 6 months. Yeah, maybe a little bit longer, Andy Weinman. The head of the CDC, Tom Frieden, was asked to leave. So there's a lot of turmoil going on. And Atul Gawande had an article in the New Yorker this week, if you haven't seen it, called The Heroism of Incremental Care. My wife sent it. She's in New York with her granddaughter and daughter. Here knew I was feeling depressed about all the changes. And so she said, you know, this will lift your spirits. And it really did. So if you get a chance to look at that, do that. So I do want to talk about collaboration, but I'm going to, here's what I want to cover. I want to tell you about practice-based research networks. Why did they emerge? And why do we have PBRNs? This article talks about the 4 pillars that we've evolved into. You know, so practice-based research networks got the big R, research, but we're more than that. And so this 4 pillars is how we've evolved. And so I wrote about it in response to Dr. Kaufman's article that he had on the HERO program. Art's a great guy. I don't know how many of you had a chance to meet him, but he's a really special friend. He's old like I am. And so we like to talk a lot, but he has the HERO program, health extension, rural outreach folks. And it was really a special program. And he wrote about it connecting academia to community. And so that's what I was commenting about. So and what I'm commenting about is a PERC. And so in a few minutes, you'll hear about what the PERC is. And then I've got some questions that I don't know answers to. And I'm hoping you're going to help. You know, what structural and behavioral changes are needed to link primary care practices to community resources? One of the things that frustrates community members a lot is why do the doctors never use us? You know, why don't they refer their patients there? You know, you'd think even a small community, everybody would be kind of doing their own thing, but you know, people sometimes don't get out of their square building, you know, and they're busy seeing patients, and the relationships haven't been developed. It's changing, and you know, and I also want to know, what does health extension in Oregon look like? Roberta was kind enough to come to talk to my group, my team, in November, and talk about the health extension program here around the state, because I think they're county extension folks. But it's amazing how many of the clinicians who I really care and admire really don't know the county extension folks. And, you know, how do we change that? And are there other people doing health extension? You know, we have the community health worker program that some of you are connected to, and we're still trying to figure out how that works. And then, you know, what I hope to spend some time is to get your advice on where are the opportunities to collaborate between what you do and what we do. And so those are some of the questions I hope to get to. This is what I do for a living. It was 1994. It was an interim report from the Institute of Medicine, just talking about what is primary care. And I mean, it took a long time, a lot of meetings to come up with this definition. And it's got really key phrases like integrated and accessible, addressing a large majority of personal health care needs, sustained partnerships. That's what Atul Gawande's article here, The Heroism of Incrementalism, was about. And practicing in the context of family and community, which I think we need to do better. And but this definition, I think, is a really great definition. You're going to see some rivers on this, so it's partly to test your geography. I mean, if you really are good and really know Oregon, you can tell me there are 11 rivers in this slide presentation. I am a bird watcher. I was talking to Sally. Sally has a rare bird in her house in Portland. She's on John's Landing down off Macadam, and this is a blue-throated warbler. And I go on Oregon Birders Online every night and look and see what people are seeing, and they've been talking about Sally's bird. I had no idea it was showing up at her house, but I also fish and hike, and so the rivers are important. So this is why I think practice-based research networks are important. This is a 1961 New England Journal of Medicine article by Carr White, who I think defined for us what primary care is about. There's, I think he's passed on, wrote this article and talked about a village of 1,000 people in a month period. And 25% of folks don't get sick. 50% of people have an illness or, get banged up, have some bruises. 24% feel like, I got to go see the doctor. And then 1%, the doctor and the patient figure, you probably need to go see the specialist about this, whether it's an orthopedist or dermatologist. But less than 0.1% receive care in tertiary care hospitals. So where's research done? Yeah, it's done up. It's done up there, and then we somehow think that the primary care folks that are out in the community ought to just adopt the findings of the research study that are there. And it turns out that doesn't always work. And so we gathered together. PBRN has been in existence since the 60s. Got accelerated in the 1990s and year 2000 with the Agency for Healthcare Research and Quality. But it's a group of practices that get together to do studies, and usually small practices. Many of our practices are solo actually, and they provide access to important neglected phenomena. Like one Oklahoma colleague that Roberta knows, Jim Molden, he wanted to know, well, what does night sweats look like? People get night sweats. Nobody's written much about night sweats. And so Jim decided to say, the other one that I liked was spider bites. People are always getting spider bites. And so they studied spider bites there. And we've done, you're going to hear a little bit about some of our work. We've done some similar things. And so we talk about community participatory research. The Reacher research, one of the reasons that I think we're important is we shorten this time period. We get the findings from research out there into practice earlier, because traditionally it takes 17 years for 14% of original research to reach patients and practices. That's a long time. And so PBRNs, you're going to hear that abbreviation quite a bit. That's practice-based research networks. Shorten that. And then we know that there are a lot of gaps in care. Glenn's done quite a bit of work on the fact that we're not providing the recommended care. 2003, it was 50% of patients with chronic illnesses weren't getting the recommended care. There are good reasons for that. Because if you're a primary care doctor and you're delivering all the preventive health services and the recommended chronic care for the group of patients that you're seeing that day, it's been studied that it would take 18.5 hours to just do that. The U.S. Preventive Services Task Force A and B recommendations and the guidelines for chronic illness care. And obviously that's not possible. So it's not because the doctors don't know. There's smart people out there. Just because they're in rural practice or in primary care doesn't mean they didn't make the grade in medical school. They chose to do that. Another river. Anybody know that river? If you know, you can just shout it out. River. Yeah, Sally was gonna get. I didn't give her enough time. But so when you look at research, particularly clinical trials, they like things to be pretty homogeneous. And so clinical trials, you get people that can read informed consents and sign them. People that usually got insurance, going to have access to doctors' offices. Not a lot, not a lot of people that are really quite ill, and so they avoid elderly. And if you're pregnant or a child, you're probably not in a clinical trial. Whereas what we do, we're in practices, and they have the full scope of patients, and so we're what we call the real world, and I think that's really true. So we wrote about it a while back. I like this diagram. So here's where I am as a practice-based research network. This is a slide that we created a figure. So we have direct relationships to practices, right? We have indirect relationships through patient communities, through the practices. So like we want to study diabetics, or we think the Latino community is an important group to study, we can reach them. So what we've solved by taking research and moving into the community, we've solved a couple of things. One of which I showed you with Carl White's slide, the location where research takes place. Moving research, out of the academic health center into the community, so it's the location. The other one's the orientation of research. And that, participatory research is not a methodology. It's just a way to do things where you practice, you conduct research with communities, patients, and the practices that they get their care in, not on these patients, and perhaps you do it with them. So it's relevant. So a lot of our research gets adapted. So one of the things we do with our research methodology is adapt it to fit local context and values. I'm going to try not to talk so much here, so I can. I'm not going to spend a lot of time talking about this slide, but we have sustained relationships with these practices and communities. I'm going to show you one slide that documents that. Is where we were here yesterday, we're here today, and we're going to be here tomorrow. And so we have a presence. So we're not doing helicopter research. This is an article that Roberta referenced that we wrote about why PBRNs are important. And the National Institute of Health, we don't get a lot of funding from NIH. We get decimal dust in terms of the amount of funds compared to if you're studying a rare disease, for instance. And so if you're studying usual care, it's harder to get it. And so this talks about the translation steps. T1 is moving from animal studies into human research. So we have clinical trials units and academic health centers. And then we try it out in some select practices. We may do phase 2 studies to see if the medicines are working. And then we think we're ready for T3, where we bring it into the practices, routine practices. And T4 is where we bring it into communities. Moving it out to the broader community. And then somebody took our slide and our approach here and said, this is what it looks like for community work. And it just describes some of the elements of a participatory approach. A lot of it is about trust and shared resources. And so making sure that we're not getting all the resources as a researcher, that the resources are distributed so the community has a stake and feels that they've got a benefit in this. I think that's a really key thing, and that goes through all phases. Even where you write up papers, we have community members that are authors on the papers, and we have an orientation to involving patients along the way. So this is one of my favorite slides. It shows one of our convocations many years ago. Ron Bale was standing up, was talking about childhood obesity and what are some of the things that we need to study. And Ron's in New Zealand now, but Joyce Hollander Rodriguez, who's up here is the Associate Dean of the Rural Campus for us. Jennifer Holliday is a family physician in Idaho. Michelle Thomas is a family physician in Wisconsin. And this is some of the steering committee where we do things together. And this was an annual meeting for us. And so you're going to hear about this. We've grown from 6 practices in 2002 to 189 practices. And so when we first met in 2002, it was in the basement of Emma Jones Hall, which is, it used to be the former nursing dorm for nursing students. So a lot of the old doctors met their wives by going over and meeting their dates there. And so they all knew Emma Jones Hall. This is like really old. It's been a house family medicine for a long time. And so we had six doctors from 6 communities introduce themselves in 2002. So now we reach about 500,000 patients. 1 in 5 rural Oregonians gets their care in an ORPRN affiliated practice. So we're starting to have some reach where the work that you do is pretty generalizable. We've done 81 funded projects. That's growing. We were one of the 10 networks around the country that was awarded a master contract. And then I am part of Meadowlark. I'm the PI of Meadowlark, which I'm a bird watcher, so I wanted to say Meadowlark. You know, it's our state bird. And so it stands for Meta Network Learning and Research Center. But it also involves Duke, Colorado, Iowa, Wisconsin, and the University of Laval at Quebec City. And then more recently, which we're just starting to work with, is the University of Toronto. And then we connect around the state, and we'll talk a little bit about why that's important to involve CCOs and payers. This is our steering committee. We are statewide. Most of these folks have been on for a long time. I keep saying, do you still want to do this? You know, like I said, we're 15 years. And so, you know, half of them are from that original start date. One of them I hired in my practice in Reedsport, Robbie Law, who's now in Astoria. He's at the top on your left as you look at that. These are really amazing folks. Sandy's a pediatrician in Ontario. Scott's in Lakeview. I don't know if anybody's been to Lakeview, but it's kind of like seeing the big cowboy that's outside of town. John Schott is in Baker City. Liz Powers is our chair of our steering committee. She's at Winding Water. She thought it ought to be illegal to have private practices, so she took her practice and it became a federally qualified health center so that she could do a lot more of the community work that she wants to do. Kristen Dillon is a medical director of one of the CCOs who was in Hood River. Jim Calvert founded the residency in Klamath Falls. Sherry Austin is the manager of Dunes Family Healthcare, which is a practice that I founded in 1977 that was funded by the Robert Wood Johnson Foundation. It has one of 13 model rural practices in the United States. And so that practice is still active. Monica DeMassi's in Albany, Albert Thompson in Pacific City, Bruin Rookies in Scappoose, and as I mentioned, Robbie's in Astoria. So we've got the state fairly well covered. This is Meadowlark, I mentioned that. We've done we're starting to do some things that get into big numbers. There are probably 8 million patients that are cared for by the practices in these networks. And we conducted one to figure out how do you do self-management support for patients? You know, what does that look like? And so we did it using a boot camp methodology where each practice brought their clinician, a nurse care manager, and 2 patients. We had 4 practices in Oregon, 4 in Colorado, 4 in Iowa, and 4 in Wisconsin. And so we studied what they developed out of that, some of the tools. These are the goals and objectives. I mentioned them. I think they're really important. It's you really have to understand the community and practices values and how do they make decisions. You know, so we spend a lot of time listening. And we spend a lot of time going into practices and communities without anything to say, here's a study we want you to do. Just show up and say, you know, what are you doing? What's happening to you? You know, and so we spend a lot of time just kind of learning from them. And because a lot of what we're finding is that we still do a lot of research around the clinical encounter, but a lot of it is affected by the local community, the health system, and the larger influences on health, genetics, social factors. This one I just came out from the National Academies of Health, and it shows communities in action. Health equity is a big issue. In rural settings, there's a lot of inequity. We have a culture of poverty in rural settings. They're poor. There are not a lot of good, paying jobs there, and so that the health services and systems are a part of what's important, but there's the whole social determinants of health. And so we're looking at, community-driven solutions when we try to address problems. And so we're having to that's why the 4 pillars was developed. We're having to step out of that model of just sticking in the 4 walls of practice and understanding what happens outside there. Workforce is a big deal. And when I started practice, there weren't, health systems didn't own practices. Now, the majority of practices are owned, whether it's a local hospital district or Samaritan Health Systems, like in Corvallis has got practices that used to be independent. They're on the coast and down the valley. So there are fewer of those. And then the thing that I like a lot here is we really need to move away from thinking that physicians are the ones that provide the whole care. The physician assistant workforce, the nurse practitioner workforce, behavioralists are really important. So we have this big initiative on behavioral health integration. And I went into Springfield Family Physicians a few months back and sat around the table and we were talking about one of our studies on cardiovascular metrics. And so around the table were 12 clinicians. 6 of them were primary care clinicians, but 6 of them were behavioralists. That's the shift. That would never have happened before. And the other thing is health information technology is huge. So everybody's got electronic health records now. And how do we use those as an aid to health instead of driving doctors nuts, which they really do drive doctors nuts. And so the steering committee came up with, what are we about? And so we get around, these are plaques that we used to give out. I don't know why we didn't do it anymore, maybe because I don't know why we don't do it anymore. But they said, well, we're about connections, involvement, and community health. And that's how they characterize what the network is. And these are folks that are busy. We own none of these practices. They do it because they feel it's an opportunity to think outside the box and to do things a different way that might benefit their practice, benefit their patients, and perhaps their community. And I'm going to talk about our health extension folks here, which are PERCs. Why do we call them PERCs? Because I didn't want to have them called the same thing that everybody else calls them. Practice facilitators is another term that you'll hear about. Coaches that are particularly related to a study, but we're more than a study. As I mentioned, we were here yesterday, we're here today, and we're going to be here tomorrow. So the PERCs, the Practice Enhancement Research Coordinators, are regionally placed around the state, and they have relationships with a cohort of practices, and they get to know the practices. And they are our boots on the ground. They provide the elbow support, and they're really smart. And the practices like them. I go into a practice, and I'll go in there, and I think I should be important to them. But the first person will say, "Well, hi, Mark. It's really good to see you." And the PERC that's with me, or "Hi, Ann." Some of those visits and know that so they go. They have built relationships so that they go through the employee-only entrance door of the clinic. That's the level of relationship that we want to have with them. And they're effective. Practices are really busy. And we know that if you have practice facilitators, you're more likely going to adopt evidence-based guidelines and do the work. This is a meta-analysis done in Canada and U.S. Baskerville was the lead author out of Canada, and they were 2.76 times more likely to adopt the guidelines. And then we tailor things to practices. This was a pediatric study that was done out of the Cleveland area, looking at fluoride varnish, screening for lead, and addressing childhood obesity. And it tailored it and saying, well, how's it going to work for your practice? How do we need to do this? So what happens in practice A may be a little bit different than what happens in practice B, which drives, the classic researchers nuts because they try to figure out how do you deal with that. But what we've also found with the practice transformation work is that they increase adaptive reserve. And adaptive reserve is the ability of a practice to withstand the chaos that goes on in the healthcare system. They can sit back and reflect on, how are we delivering care to our diabetic patients? Let's talk about that for a little bit. That takes some adaptive reserve. And the practice facilitator can help build that capacity. Let's figure out how we're going to use our EHR and get people know who our diabetic patients are and what do they look like. And these are our perks. And what kind of credentials do they have? They usually have like an MPH. They have some, I think everybody up here's probably got an MPH. They may have some additional credentials. I can't remember all the initials. And so they're placed around the state. Offices on the campus of Eastern Oregon University, Southern Oregon University, Hood River. I don't know why there's not an arrow there. I guess we need to put one there. And then Eugene and Bend. And then we have office in Portland, where we're headquartered at OHSU. But we've really evolved into a learning community. So we spend a lot of time working together. This is a convocation that happened last year. And Art Kaufman, for those of you who's here with Bruce Goldberg. And so Bruce Goldberg is our senior associate director. Bruce used to be head of the Oregon Health Authority. He was the architect of the community coordinated care organizations. So he worked under Kulangowski and then Kitzhaber, and then resurfaced working with me. This is our 4 pillars. Anybody know this river? I boated it.
Rogue?
It's a Rogue, Blossom Bar. Yeah, it's kind of scary. But this is the 4 pillars: community engagement, building the motivation and increasing capacity to do research, practice transformation, connecting practices and delivering services. We have medical homes here in Oregon, and they need some help with it. Research is a community asset. It's not like Tuskegee where we're experimenting on you. We're going to use you as a research subject. We think this is an asset. Let's understand how this research might apply to your community and what might it change. And then education is huge. We work educating the community and the physicians, but we also work with the educational systems here in the state, NAHEC. We do research around these different projects. I'm going to try to leave some time here, so I am wandering a little bit through this. Here, this is our research spectrum. Has absolutely no validity. Melinda Davis, one of our research coordinators, used to be a PERC, said, I think I'll just kind of decide what's low collaboration, what's high collaboration, what happens in the clinic, what happens in the community. And so she just put up a sample of our research. And we're going to have a real fight about where these actually fit in when we get together as a staff. So unmet dental needs. It was the community said, the doc saying, we're seeing people and having to pull their teeth, because they can't get in to see the dentist. And so they said, we want to study that. So they decided to study that. In step was the patient self-management support one that I talked about. CPC's practice one that's directed at the clinic here. Cascade is a pragmatic clinical trial that's been funded by the NIH, and we're doing it in Metal Art. And it's where from age 0 to 2, every day kids get lathered up with Vaseline or Aquaphor or sunflower oil. Why is that, do you think? Why do you think it's important to, anybody want to take a guess? So it's the skin's, kind of open to everything. So this forms a barrier. So we're studying a reduction in atopic dermatitis, hay fever, and asthma with it. And there's good evidence that this works. And so we're trying to do this in the real world, in practices in those academic settings. This is our biggest project that we're working with 100 practices to do practice transformation and understand the million hearts metrics, which is aspirin for patients that should be on it that are at risk for a cardiovascular event, blood pressure control. 1/3 of the people in the United States have hypertension. Only half of them are controlled. Optimal cholesterol management. Not everybody likes to take a statin, but other people think a statin should be in the water. And then smoking cessation is still a big deal. So, we have, maybe 18-19% of people that smoke. And so this is our QI methodology with these high value elements. Here in the PERCs work with this. I mentioned that we were here yesterday and we're here tomorrow. This is 2003. We worked with this practice in Eastern Oregon, Baker City. John Schott said, LJ, we wouldn't be here today if we weren't working with ORPRN and doing the work that we've done with you over the years. So let's put it out. So we did an immunization study, early childhood immunization, chronic kidney disease study. Went through a couple of EHR transformations, a child medical home project, and in 2013 they were selected as one of 30 practices in the United States by the Robert Wood Johnson LEAP program, learning an exemplary ambulatory practice. And then they're doing Healthy Hearts Northwest with us. Determinants of health, I mentioned that healthcare is just a small part of it. This is where, we have a hard time getting patients from primary care over to community resources. We don't know how to do that. And it's a challenge. And so an opportunity to activate patients, opportunity to encourage. We haven't developed that relationship. And so we have a lot of unanswered questions. We wrote about our website here. Again, this is our interpretation of the bridge. So you'll be able to click on that and see what our research questions are around those things. So, cool, I got to do this. James was working with me to get this set up. So we're going to, this is how we do community research.
Community engagement and public participation in research are important in generating knowledge that can help translate research discoveries into routine practice. 1 in 5 Americans live in rural areas, but often don't participate in initiatives because they live far from academic medical centers. Researchers at the Oregon Health and Science University developed the CHIP to CHIRP program to expand research partnerships into rural communities. CHIP to CHIRP builds on 4 well-established community health improvement partnerships, or CHIPs, by adding research training to transform the groups into community health improvement and research partnerships, or CHIRPs. CHIP to CHIRP builds trusting relationships and establishes a foundation for sustained research collaborations.
Trust is a really important component of relationships in general, and I think in participating in CHIP to CHIRP and in participating in community academic research partnerships in general, it could either enhance trust or it could undermine trust. And a lot of that is based on commitment that's set up front about and communication about what each partner needs.
Community partners participate in CHIP to CHIRP to develop skills, understand how evidence-based programs are developed, and learn how to evaluate what works and what doesn't for their local communities.
The main reason I want to participate in community-based research is that I live in a community and I feel like the organization that I work with is always taking on projects, and my concern is how to do them so that they're fundable projects. We have data that emerges from that project that really shows that we've been effective in the programs that we're doing.
The Chip to Chirp program kicked off with a symposium at Oregon Health and Science University. Community members went on a guided bench-to-bedside tour across campus. They toured basic science labs, clinical research facilities, and attended presentations by population and community researchers to learn more about how research translates from test tubes into our everyday lives. After the presentation, community members participated in a facilitated meeting with potential academic research partners. Together, the groups explored best practices for building research partnerships in rural areas.
One of the things we really did in Chip to Chirp is talk about these are the demands that are on an academic partner, as well as we had the community share about what are the pressures and what are their concerns and needs. And we did this at our initial symposium where we brought community members to OHSU as well as academicians to come together in an afternoon to discuss this. And so really I think a shared language for what are some of the different demands on these stakeholders, and then how can we ideally meet a happy medium where we can come together so that each partner can have, their needs and their goals met. I think ideally that does build trust because you work together, you might have some challenging conversations, but you move forward.
Over the next 4 months, CHIRP members participated in 8 research training modules designed to help them understand basic research and prepare them for collaborative research partnerships.
Well, the training that we got about research was a real eye-opener, I think, in how you have to go about it. I think it's important for people to understand what it takes to do research, and hopefully as a basis for future research into health and things related to it.
As part of the program, each CHIRP group received a small grant to develop a 3-month pilot study addressing childhood obesity, a health concern all 4 communities independently identified as a local problem. The pilot study allowed community members to participate as stakeholders in all phases of the research process, from idea generation through data collection, analysis, and dissemination. The 4 pilot projects explored chocolate milk removal in school lunches, looked at barriers and facilitators to using recreation services, tested an educational curriculum that teaches high school students to read nutrition labels and shop for healthy foods, and explored the effectiveness of pick-of-the-month food flyers and tasting tables on eating habits. The results from the pilot studies are being used to inform school and community policies.
It's giving us a core of information which I hope will enable us to keep doing these kinds of studies, because I think we can have a real impact on the community. We've been given a lot of tools, a lot of techniques, and I feel much more capable of participating in your study.
We like to think that we can help provide some information, like you said, for the field, but also regionally to maybe make some policy changes.
Oregon Health and Science University researchers are working to connect CHIRP groups with investigators from around the state with similar research interests and to expand this approach into other communities.
I think the group is excited to go further and try to keep expanding on the research we're doing. So I highly encourage people to get involved in processes like this.
I love local research. I think it's cool.
So that was our Chip to Chirp, and I can talk about that a little later, but I'm going to move on here. So this is our research training. We had 8 modules. So the NIH funded this. They're really high quality. There are also a bunch of YouTube modules that you can look at there. We would look for opportunities to how we can use this Chip to Chirp model. To be really honest with you, it's pretty dormant right now. It was really a great program, but we really haven't taken advantage of what we developed. So here's my kind of take on extension programs. There's the work that you folks do here at Oregon State University as a land-grant college with the extension program. I don't know much about it. Roberta was trying to educate us some about it. We have a long ways to go to understand that. I think one of the best ways to understand what you do and what we do is to maybe do a project together. I think that, to me, we can sit and talk about it for a long time, but until we actually start doing some work together, we won't understand what each of us brings to the table. And then this is the toolkit. I'm not going to click on it because I want to hear from you hear about what you heard today. Roberta and I were participants in developing this toolkit. Art Kaufman and Jim Mold and others were doing some heavy lifting. I don't know, Roberta, do you want to say anything about the toolkit?
Well, just that it's a model again for mostly to bring the academic health professional world into communities using extension as a model. And so it was originally in the Affordable Care Act that it was, health extension was a big thing, and it was never funded. Commonwealth ended up funding it. And then it kind of exists now as a toolkit available that some states are using to design projects like this.
Right. So the Affordable Care Act had written in the Primary Care Extension Program, PCEP, and so we've been doing some of that unfunded. I mean, we just try to figure out ways of doing it. So the ARC had an impact grant, Commonwealth helped fund Dr. Kaufman, and we developed that toolkit. This is my last slide. Anybody know about this river or been on this bridge? Yeah, so it's the Willamette, right? And so my office is right on this side of it. And it's a 2-story brick building. I'm pretty sure it's going to be demolished because OHSU wants to build big buildings and look fancy, and mine's a little brick building that houses some of our outreach programs. And the bridge is really cool. That's the Willamette that it goes across. Our website's there, my email's there, send me a note. But what I want to do is kind of hear comments and address any questions that you folks might have. Sorry about galloping through this, but I wanted to share it with you and share this community lab. Yes.
Would you comment on the Rural Practice Network, ORPRN, and potential connections with Extension, and then public health, county public health, or local public health? Your thoughts of how those things work together?
Yes. The immunization program was probably one that we did, our Rural Oregon Immunization Initiative, where we young kids would get their shots sometimes in a medical practice. Sometimes they would get their immunizations at the health department. And we wanted to understand what that looked like and how are we communicating. Out of this, we were able to enhance the use of the immunization registry around the state. So it doesn't matter where a child gets their immunization, anybody can get access to it, if you're a health department provider or a clinic provider. So we brought the county folks who were part of the public health division together with the practices to talk. And they'd never talked before about, who are you seeing, what are you doing, how can we help you? Last year we had a problem with the refrigerator. We ran out. We didn't know we could go over to your place and get the vaccine and maybe pay you back. I think that's one, might be one area. We have not figured out how to use community health workers. So community health workers, we have some practices that are really advanced that actually hire community health workers, so they're within the practice. Other community health workers are funded by the coordinated care organizations. Some are funded by health systems. There's not one model out there, and we don't understand what their role is in improving population health. And I don't know what their role is with the extension programs out there. And, so I think we need to kind of describe that a little bit. We're missing that. From my standpoint, we need to get beyond the walls of the practice out into the community. And when we do that, we're going to kind of identify issues of need. One of which is we have a nutrition institute. Kent Thornburg's going to talk to the steering committee on Monday and want to brainstorm around research ideas around community nutrition. What do the doctors in their practices do about nutrition? I don't know what they're doing. I think extension does quite a bit. But again, I don't know what you're doing, and how do we bring that so that practices can benefit, because practices are the entry point for the healthcare system, primary care practices. They're the front door of the health system. So what we built is this relationship with practices which are highly valued by the community, but they are not connected to community resources. And so we're not taking advantage of what you're doing and what some other folks have put into place. Yeah.
I have a question about the potential for generating community health data that would be more indicative of community population health improvement. Right now, there are a lot of efforts that are aimed at improving population health, but then the data aren't there to demonstrate that those efforts are actually effective.
Right.
Improvements, and so that I'm curious as to how this might actually contribute to.
Yeah, so I think that there's a fair amount of interest in social determinants of health these days, and so we're a finalist for the Medicare Accountable Health Communities program, which is going to be done in Central Oregon. Southern Oregon involves about 4 CCOs and a number of health systems, and where we were going to screen people for social determinants of health, housing, food insecurity, drugs, substance abuse, and it was going to be routine screening, and then we were going to have navigators take them through those that screen positive to get them services, and the primary care practices were going to be a part of that as well. So some of the screening would take place in primary care, but it wouldn't just take place there. Where else could it take place in a community to identify people who have needs, whether it's employment or transportation. We don't have a lot of, we have data. So the Office of Rural Health, Emerson Ong, creates a 6-page community profile for me. So I can get more morbidity and mortality data at the PICSIS unit, which stands for Primary Care Service Area. And so we can get pictures of employment, workforce data. I don't know if you've seen it, Ann, but I can share with you what a copy might look like. It's a wealth of information, but we've never sat around and talked about it. And, let's take a look at that and have a conversation about, is this data right? Is that kind of what you're interpreting? Things that has, kids on free lunch programs, food stamps, employment issues, a lot of things. It's a 6-page community profile. And so we have data, but it's being brought in from multiple sources. But the Accountable Health Communities Project will bring in, we'll put the in a single repository, so we know we're getting real-time data that we can trust. We haven't had a project that's able to do that. Yes, Ann.
So when you were talking earlier about looking for some potential projects that we might be able to work on, the last one that you just mentioned, what were the areas again that you mentioned? Was it in Southern Oregon?
Yeah, Southern Oregon is Central Oregon, and so it's a partnership. We're the hub if we get funded. So we heard we're finalists, and who knows, because of what's going on in Washington these days, we have no idea what's happening with kind of our proposals that are out there. But what would that look like? I would think that extension would need to play a role in that.
Yes, and a couple of other potential connections. Not only does Extension have a strong presence in all of the counties throughout the state, but we also, our community health worker training program is going to be holding its first training in the southern part of the state down at Goose Bay in partnership with Southwest Community College.
Right.
So that's going to start in April.
Right.
And then in terms of some data, data collection methods, it seems like we have a lot of potential areas that we might be able to collaborate on that project.
That would be great. So we have a PERC that services that area, and then we've been working with WOA, which is the CCO for that region, and they're one of our nodes for the rural campus. Carla McKelvey's the pediatrician, the associate dean for that. So we have some potential to talk. Yeah. Other comments?
One more
yes,
question.
please.
And that is, when you were talking about some of the other states that you've been involved with through the Middle East program, are you familiar with any of the practices in those states having the connections with extension offices for, are you familiar with how they've been working together?
Yeah, so I'm not so much in, well, actually in Colorado. Colorado is trying to pilot a program, trying to figure out how to bring extension in. I forget what they call it. They're hiring people, which are regional health coordinators or something, that try to bring everybody together because everything's siloed. And so I think Oklahoma's done a pretty good job. They haven't been they're not part of Metal-Arc, but they've done a pretty good job of trying to develop a statewide single health extension model that everybody fits under, so that everybody can still have their own identity and they can do the work that they're good at, but that it's kind of coordinated and building synergy. Right now it's not, it's just kind of people are doing, and there aren't conversations that I'm aware of in most places. I'm not aware of it in this state.
I saw a lot of people that I knew on your chip video.
Mm-hmm.
It shows that Oregon is actually a pretty small state.
Mm-hmm.
But I think that there's lots of ideas that we have and expertise that the land grant has that we could do some smaller projects or even bigger projects together that we, like you said, we just need to stay on top of.
Yeah, and I'd be happy to do that because, and there's lots of logistics around, the thing that drives projects are budgets,
Mm-hmm.
And figuring out, and I'm okay having and I'd welcome having PIs, principal investigators, that are at OSU working using our laboratory. We can always figure out about kind of how to share resources and share indirects. We can build, their models for that, and vice versa. We may have a project that we've got somebody that wants to be the PI but wants to utilize some of your resources and expertise. And so it's, we need to talk about just doing it. Mm-hmm. Yeah, thanks.
I think, one more question.
Please.
And I can ask you later, but my question was related to, you talked about using behavioralists in one of your projects. Do you ever look at behavioral outcomes or mental health outcomes within your research?
Yes, so we're still in the early phases of what that looks like. So when most people talk about behavioral health integration, they think about a primary care office bringing in behavioralists and working with them. We actually have a study where we worked with 13 behavioral health organizations and are bringing primary care into them. And we're studying quality of care metrics for diabetes and hypertension and figuring out, can they deliver reasonable primary care? Because a lot of people that go to the behavioral health clinic, that's their usual source of care. Their mental illness or behavioral issue is kind of, that's where they go. And so they should be able to get primary care there and not to have to go to separate places. And so we're trying to figure that out. I don't think we have any long-term, still pretty early. We don't have any long-term data. I think we have some patient satisfaction and practice satisfaction data.
Okay. Well, join me in thanking Dr.
Yeah.
Fagnan.